So, hi, I'm Mahesh Menon.
Hi, I'm Smriti Khanna.
Welcome to another episode of our podcast, Living Well.
Today on this episode, we have Professor Julia Downing. She has very kindly agreed to come on as guest on our podcast. Thank you so much, Professor Julia. Do you mind telling us a little bit about your journey in the world of children's palliative care?
Okay, thank you very much for inviting me. So, I'm a nurse by background, and I grew up in the UK, and I was one of the early nurses to do a degree program. So there was only 12 of us on our program, and I did that in Cardiff. And as part of our degree, we were allowed to do 2 electives. And I was lucky enough to work at St Christopher's Hospice with Dame Cicely Saunders on one of my electives.
Oh, wow.
And
Wow.
I just saw the difference that palliative care could make. I'd been working in a ward where when somebody was dying, they were moved into a single room and nobody wanted to go in because they didn't know what to say. So my time at St Christopher's just completely changed what I saw was possible. And also as a nurse, I saw the difference that I could make. And also my other elective was in Zambia, and I kind of fell in love with Africa. So after I qualified, I trained as an oncology nurse and then in palliative care. And then I moved to Uganda. I saw a job advertised. I'd always wanted to go back to Africa. I moved to Uganda, and that was actually 24 years ago this week. And
wow.
I went for 2 years, and I'm still going back and forth to Uganda now. So I went there. I was working in an HIV/AIDS and palliative care organisation that cared for children and adults and really provided family-centred care. And I saw the difference again that in HIV at that time we didn't have antiretroviral therapy. So I saw the difference that palliative care could make. And whilst I'd done some paediatrics in the UK, it was really there where my passion for paediatric palliative care grew and developed. And then I worked for the African Palliative Care Association and then for the International Children's Palliative Care Network. So initially as a consultant and then more recently as the chief executive. So started working in the UK, then moved to Uganda, then across Africa and now globally. So it's been quite a journey. And if you'd asked me when I started training as a nurse, would I be doing this? I would have had no idea this was what I was doing.
That's so beautiful because you mentioned that you took up an elective in palliative care. Now, my question is, had you not taken this elective and had you not been at St. Christopher's, do you think you would have chosen palliative care, or do you think it was just
I don't know.
serendipity?
It was just meant to be.
Yeah.
As soon as I was there,
Yeah.
I just felt an affinity for palliative care, and I just thought at some stage that was what I was going to do.
Yeah. I wanted to talk a little bit more about the ICPCN. Now we know that it stands for the International Children's Palliative Care Network. But could you tell us a bit about the background and the kind of work that it has done?
ICPCN is 20 years old this year. So it was started back in 2005. And some colleagues went to an event in Seoul in South Korea. And it was an event for national palliative care associations. And they felt that much of the discussion was about adults.
Yeah.
And there was nothing about children. And
Yeah.
so a group of 4 of them decided that we really should have an organisation that focused on children's palliative care.
Wow.
So that was when ICPCN was first born. And the key people there were Joan Marsden, Barbara Gelb, Lizzie Chambers and Peter. So it was a really key group. And ICPCN was formed. And initially we had a steering committee, and Barbara and Lizzie were the co-chairs of that. And then eventually ICPCN became registered as an independent organisation, and we had a board. And again, Lizzie and Barbara were the co-chairs, and Joan Marston was kind of the chief executive. My involvement, I actually got involved right from that steering committee.
Wow.
So I was in the initial steering committee, and then part of the first board, and then I came off the board and started doing some consultancy for ICPCN. So it's been a 20-year journey from very small beginnings, but from a real passion for children's palliative care. And the organisation has grown in terms of its global reach and hopefully its impact over those 20 years. Our key areas of work at the moment are, we call it ICPCN Cares, so communication, advocacy, research, education, and strategic development. To try and make sure that palliative care becomes available for all children and families. So there's currently around 21 million children around the world who need access to palliative care, and it's estimated only 5 to 10% have access. So that's over 19 million children around the world and their families who are suffering because they can't access palliative care. So we've come a way in 20 years, but we still have a long way to go.
So I want to take you back 4 years before the ICPCN was formed. You know, that's about when you were in Uganda. You mentioned that you were there 24 years ago. And what was there any specific trigger that caused you to lean more towards pediatric palliative care? Your work with HIV and AIDS, but are there any anecdotes, any specific things that caused you to take this up as a commitment? That's something that you'd see you doing, or was it just something that you said it's part of the process and I'm going to go through with pediatric oncology training and so on? It's just an extension of what you did, or was there something that triggered you to go specifically into pediatric palliative care?
There was 2 children that we cared for, one of whom was found on a rubbish dump, and half of his face had been eaten by maggots, and he wouldn't look at anybody, he wouldn't make eye contact, he cried, he didn't speak, and
Abandoned?
Pardon?
Abandoned,
he was maybe about 18 months, we didn't know his age, and he was only with us for about 6 weeks because he died. But in that 6 weeks, I saw the difference that we could make. Before he died, he was smiling, he was laughing, he was making eye contact. He was a different child. And the difference that we could make was really powerful. We had another child called Sarah, and again, we cared for her for a couple of years before she died. But again, I saw the difference that managing her pain, managing her symptoms, but also thinking about the total care. So those 2 children, amongst others, but also at the Malmö Centre where I was working, we had more children with HIV than at that time were known to have HIV in the whole of the UK. And the impact of that kind of hit me as well. And there were many treatment centres that really weren't providing care for children. The other thing was that I lived on site, and I used to see the children every day.
Morning, evening, all the day.
But before I went to Uganda, I had cared for one girl several, but there was one girl in the UK called Sechi, who was from Turkey, and she'd come to the UK for treatment for cancer. And again, sadly, she died, but I learned so much from her. So that kind of had sowed the seed. And then when I was in Uganda, it kind of developed.
There's some things that I wanted to know about the ICPCN. You say that this is CARES, right? Communication, advocacy, and this is just a group of people that has come together with a common goal in mind and said, okay, let's create something that we hopefully has a good impact. What are some of the specifics that that ICPCN is doing, say amongst these?
Okay, so I mean, communications, trying to tell stories, trying to get information about the impact of palliative care on health professionals, doctors, nurses, clinical officers, social workers, religious leaders, everybody working, teachers with children, but also trying to tell some of the stories of families, the difference that are just made. And we edit the International Children's edition of eHospice. So that's one way where we share stories. We've had publication in the past, Touching Rainbows, which was telling stories of children from around the world. And as part of our 20th anniversary, we're hoping to publish another book similar later in the year. But also communicating about what's going on around the world, about education, around putting people in touch with each other, because we don't need to reinvent the wheel all the time. So those connections between people in different countries, different parts of the world, obviously social media and all that sort of thing, and also communicating about children's palliative care. When people ask what I do, and I say children's palliative care, they say, "Oh, isn't that depressing?"
Yeah.
And, the conversation stops. Yeah, but I say no, because to me it's about life. It's about enabling the children and the families to have the best possible quality of life. And I feel it's a privilege to walk with the children and their families. So it's about communicating that as well. Advocacy, we work a lot with the World Health Organization and other global organizations, regional organizations, to raise the profile and the need for children's palliative care, to make sure children's palliative care is included in documents, the WHO resolution, the Lancet Commission report, getting children on the agenda.
Visibility.
To make them visible.
To make them visible. And, if you look at the work from the Global Atlas published by the WHPCA and the WHO, children only account for maybe around 7 to 8% of all palliative care need. And so it's very easy for them to get missed. And there's much more voice for adults. Also, the children are, when they're very young, they don't have their own voice. And so really making sure that voice is heard. So that's a continual advocacy role for us.
And do we have any statistics on the need for palliative care in children from countries like India or any countries like low and middle income countries? Are there any statistics out there? Or?
So that's an interesting question, because we published the study back in 2007 that showed there were 21 million children around the world.
21 million?
Yes. And we've thought that was a bit of an underestimation. But we published that, and then currently there's a paper just about to be submitted that has worked on the calculations from the Lancet Commission report, which didn't really cover children properly, and the numbers were quite low. So we're re-looking at that. But I can give you a rough example. So when we did the study in 2017, the number of children needing palliative care per 10,000 was, in the UK, it was 32 children per 10,000.
Okay.
In countries like Zimbabwe, South Africa, it was more like I can't remember the exact, but it was 120
It's about
per
4
10,000,
times,
so 4 times
More.
as high. And even though the need has gone up in the UK because children are living longer,
Yeah,
the need in low-income countries is still a lot more
it's much
higher.
more.
And the resources are mismatched.
The resources are mismatched. So if 98%, between 96 and 98% of children needing palliative care are in low-income countries, and yet most of the care provision is in high-income countries. So there's a big mismatch.
So not only
there.
are there more children in these countries who need palliative care, and these children don't have enough resources to help them with.
Yeah. So our advocacy role is key, but also linked to that is our research role.
Yeah.
So why we did the original study was that the World Health Organization said to us, well, how many children around the world need palliative care?
Yeah.
We didn't have an answer. Now, no study like that is going to be, 100% accurate. It's an estimation.
Correct.
But even doing that, so the original study, we looked specifically, for example, at Kenya. And when we shared the results with the government in Kenya, because we found that about less than 1% of children in Kenya needing palliative care could access it, the government said that's not good enough. So we were able to use that data to then get governments to
Take notice.
So
very
research and data is important. One of the things, for example, the World Health Organization guidelines on managing pain in children continually say there isn't enough evidence. So that isn't the data.
They do that.
There.
Yes.
And actually getting that data is quite hard. But we need to expand the research. And we need to expand research not just in individual countries, but across countries. So one of our roles in research is trying to link in with kind of multi-country research and trying to bring people together for research, but really thinking about what is the important data. So another example is we often get asked, how do you measure the outcomes of children's palliative care?
Yes.
So we've been very instrumental in the development of the Children's Palliative Outcome Scale. And that started initially in the African region, and now it's spread to other regions and in the UK and things. So that's one area of research that we've been involved in over the years.
Yeah. So it's usually something that is devised in the global north, so to say, is something that comes to the global south, or tools that are designed, say, in the Western world are usually brought to Asia and Africa. You've given an example of an outcome scale which was designed in Africa, and now it's being used
going everywhere.
And that's really key, isn't it? Because also if you look at the research on children's palliative care, the majority of it comes from high-income countries.
But this is where the need is, right? The need is more in Africa.
The need is more in the low-income countries. So we need to encourage the research. But there's less people involved. And, when there's fewer people, if there's only one or two consultants, for example, in children's palliative care in a country, they're busy seeing the children. And we also
time
need
for
them
the
to
research.
do education. We need them to do research. We need them to do advocacy. So it's challenging. And then, of course, education is key.
Yes.
So how does ICPCN help these consultants?
How do we help these consultants? Well, in different ways. I'll give you an example. So I've just actually come from Ghana, and we've been working with World Child Cancer in Ghana, but we've been working with the Ministry of Health, the Ghana Health Services, a whole range of organisations in Ghana, where they have one paediatric palliative care specialist who was trained in South Africa. So over the past year, we've done some training for 128 health professionals from across Ghana, doing some face-to-face training, clinical placements, mentorship. They've had action plans, various things that they've been working on. We've also started to work with the Ghana colleges of physicians and surgeons, nurses and midwives and pharmacists to get children's palliative care integrated into the systems in Ghana. And we're going to be working with them for the next couple of years. So hopefully there'll be some membership and fellowship programs in Ghana so that we can increase the number of consultants and specialists in that country. So
you know what I'm thinking of?
that's one example.
I'm thinking of someone in Ghana who faced a similar experience when you went to Seoul and saw that there is not enough work in pediatric palliative care.
And
Then
then that
someone says,
person.
there's not enough work happening in adult palliative care. There's so much work happening in children's.
No,
Very
but
inspiring.
when I go to the ICPCN website, there are a couple of things that really have struck me every time I have gone onto the website. One is that they have a children's palliative care directory.
Okay.
And this is a worldwide directory, isn't it? And so if I need to see if there is any child anywhere in the world, where do they need access to palliative care, I have it.
Of all the
it's a
professionals?
resource.
Okay.
It's not 100% complete because things are
Yeah.
developing.
Yeah.
So
Yeah.
we encourage people, do let us know
keep-
if you've got
yeah.
a service
Yeah.
so that we can put you
And
on
are
the
they
directory.
necessarily ICPCN members?
They're not necessarily ICPCN members, no. And one of the things we often do is put people in contact.
Yeah.
So I can give an example of service in the UK. It was Great Ormond Street. They actually had a child from Kenya who wanted to go back home and die at home. So we were able to put people in contact, and they were able to support each other, and the child was able to go home to Kenya and get good care before they died. So that's another area that we do. We kind of put people in touch so that these things can
So
happen.
that's a great way to collaborate and just
It's a
make sure
network
that
then,
everybody is getting the resources they need.
And one of the things I'm just using this child as an example was, well, what medicines did they have available in Kenya? Because they didn't want to send the child back to Kenya with medicines that they then couldn't access.
Yes.
Yeah.
So they got them stable on medicines that were then available in Kenya.
Yeah, because they wouldn't want to take a discharge if those same medicines are not
Aren't
available.
available. The other thing that I find really striking is that they have an e-learning program, ICPCN's e-learning program. That was actually my first e-learning that I ever did in children's palliative care. When I joined.
How old is this e-learning program?
Well, we started it in about 2000. The pilot was in about 2011, 12.
About 10 years before the rest of the world decided to go
Yeah.
e-learning.
Yeah.
And
And now I think
it's so specific because I still remember the morphine dose for children because I read it on the ICPCN website.
Okay.
That's where I first read it in an MCQ. It's very specific. It's very the subdivisions of what you need to learn.
Very
structured. There's text and there's MCQ based questions. It's an excellent e-learning program. It allows you to learn on your own pace. You can do a few modules, come back later, and then get the certificate of completion. Some of our we in India have started through the Indian Academy of Pediatrics. We have started learning programs. You have taught on some of them. Sometimes we require, for the advanced course, when we require certification, we actually rely on ICPCN certification.
Okay.
So if you haven't done the basic course, the one that the IAP has prescribed, you can do the ICPCN certification online and then get into the advanced course.
And we can tell when you've said that because suddenly the numbers from India
have gone
come
up.
But the programs are available. We keep adding to them, and we're just about to this year update them all. But they're available. I think it's now 14 different languages.
Wow.
So they're not all available in every language, but they're all available in English. But some of them are available in a wide range of languages.
So this e-learning that you mentioned, is it doctor specific, or is there a nursing training program?
It's multidisciplinary.
It's multidisciplinary.
It's multidisciplinary, yeah.
And is there any specific focus on nursing education? Anything that ICPCN is doing? Because you're a nursing background, so.
So yes, I mean nursing education. We've literally just edited a book that's come out this year on children's palliative care nursing.
Wow.
So a 2025 publication. And we've done quite a bit of nursing focused training. We've recently run a leadership program for children's palliative care nurses. And obviously we're involved in leadership programs here, which is multidisciplinary.
Too, yeah.
But obviously, I always say I have two passions: children's palliative care and nursing. So when I can bring the two together, to me that's really important.
Yeah.
And one of the things that I feel is that I'm not only advocating for children's palliative care, but I'm advocating for nursing.
Too.
So I also support some of the nursing work at the WHO with the International Council of Nurses, and there's a global palliative nursing network, and ICPCN were key in helping found that with St Christopher's Hospice. And we've run conferences for initially for pioneering nurses, but for nurses from around the world who really want to learn more about what it is to be a palliative care nurse.
Lovely.
And that's for adults and children. Nurses.
So that's for both.
That's for both.
I was very curious about your work in Uganda. I think that since you went there about 24 years ago, that was probably palliative care was not known quite well at that point of time. Did you encounter challenges to try and establish it, to try and teach it, to try and get it into practice?
Yes, I mean, there have been challenges. Access to medicines is one.
Yeah.
We've trained lots of nurses, and we've trained nurses who are able to prescribe for palliative care.
Okay.
So specialist nurses can prescribe morphine and other medicines, because in countries like Uganda, there aren't enough doctors.
Yeah.
If in the rural settings, particularly, if nurses, specialist nurses can't prescribe, then patients can't access medicines.
Yeah.
So are you saying that Uganda has a specialist nurse-led program also? Like they can manage that? Yeah.
Yes. And we did a few years ago, we did a research study. So we were running a leadership program for nursing, and we were trying to help them to develop their research skills. But we evaluated the nurse prescribing program. So it was kind of a twofold, encouraging people. So we actually had 40 nurses from around the country involved in the research. And we were able to show that the nurses were competent at prescribing, but also that they knew their limits, so they knew when they needed help, and so it was important for them to have links as to who to call. And it was interesting because the WHO asked us to evaluate the program, and initially they wanted us to compare doctors prescribing with nurse prescribing.
Yeah.
And we said no, because the nurses were prescribing where there were no doctors.
Yeah.
So it wasn't the matter of who did it better. It was, can they do it competently and safely?
Yeah. I think that's the key question, right?
Yeah.
So this is like a nurse practitioner role.
It's like a nurse practitioner role. Now, the other challenge, you asked about challenges, is getting that role adopted by the Nursing Council and and the government, and then having government positions for those nurses around the country, and that's still ongoing.
And I think that is a challenge that we are facing, because in India we don't have nurse practitioners.
Yes, so in India there are different systems of medicine. One is, of course, the Western system of medicine, and there is a system of medicine which is called the Ayush, which has been here in place for a long time. And a lot of times there is discussions about practitioners prescribing medicines. And the reason is because there is not enough reach for doctors in many areas, and these are the only doctors for miles around. So we just need to ensure that all of it falls in place. And just thinking about this, the role
How
for
do
a
you
nurse
evaluate?
practitioner.
Yeah.
And what you said makes sense, that it's not about comparing the two, but to ensure that the person who requires treatment, who requires medicine, gets it. Yeah.
That's the important thing. And actually, the reality is, so certainly from my own practice in the UK, before I moved to Uganda, was that often, like, we would write it and the doctors would sign it.
Yeah.
And that was even when I was working in oncology. I'd write all the chemotherapy scripts and the doctors would just sign it. So,
But I really liked that idea, like extrapolating this. Okay, even though we do not yet have a nurse practitioner role already in place, we have Ayush practitioners. How can we then think about evaluation in terms of competency and safety?
Competency and safety, yeah.
And also the issue as well is how well are the nurses trained in the first place or educated. So I worked in a Eastern European country, and nurses there were trained at secondary school levels, so between the ages of 16 and 18. So their qualification was not higher than a secondary school. So before you could even begin to think about nurse prescribing, you had to try and develop the nurse education, and it is being developed, and there are now diploma and degree courses for the nurses. But so you have to start with where the nurses are. You can't just go in and say, right, you should all have nurse prescribers when the nurses aren't trained at that level.
Yeah, I think that makes a lot of sense, and it's wonderful to hear you advocate for nurses so much. This is something that I often think of, that sometimes even in healthcare we get jaded. Those of us who, students or young people who want to enter healthcare, who want to make a difference, they keep wondering, okay, I am just one person. How can I make the change? What is it that I can do? What would you like to say to them?
So we have a phrase that we often say in Uganda and other countries, is that if you think you're too small to make a difference, try going to bed with a mosquito. Because the one tiny mosquito can keep you awake all night. Each one of us has a role to play. And, we learn, as a nurse, I learned very early on in my nursing career how to advocate for patients. I learned how to, if they needed access to medicines they couldn't get, I learned how to stand up and say, we need access to this. I found it a lot easier to stand up for the patient than I did for myself initially. But I learned those skills. And right from clinical bedside nursing, from when I qualified, I was leading a team of nurses. So I learned right from the beginning. And I think one of the key things for all of us is to take any opportunities that we are given. So, for example, I remember being asked if I would help develop some pain assessment tools. I think that was the first thing I did for the hospital, and I'm like, oh my goodness, I'm just qualified, and I'm, I'd done my thesis at university on pain and pain assessment, so I knew a little bit, but and I did, and I learned a lot. And then I got asked to do something else, and I think we need to, whether we're a nurse, a doctor, whoever, step outside our comfort zone sometimes. And when you do that, you see things change. You see that you can make a difference. And whether it is, depending on our role, are you making a difference for the patient? Are you making a difference for the other nurses or health professionals or the palliative care team in your hospital or in your district or your region or your country, or, it spreads out. But you take step by step. You say yes, even if you're thinking inside, help, I don't know how to do that.
Yeah.
And you grow in confidence. You know, my mum always says that when I was growing up, I was very shy and I would hide behind her. I wouldn't talk to anyone. And so the thought now of the fact that I'm quite happy, I still get nervous, but I'm quite happy to stand up in front of people and speak and teach, and you know, and that's because I gradually stepped out of my comfort zone and I took some opportunities that were given to me, even if I didn't think. You know, I went to Uganda. I signed on the dotted line initially for a 3-year period. I'd never been to Uganda. I didn't know anyone in Uganda. And I confess I cried most of the flight from the UK to Uganda because I thought, what am I doing? And I have never regretted it. That's changed.
That's lovely.
Changed my life. So
That's lovely.
if you get opportunities, take them.
Take
and
them.
never underestimate the difference that we can make.
No, as especially in India, we go to bed with many mosquitoes at night sometimes. So we don't we realize the importance of this example that you've given. You were just recapitulating the challenges that you faced in Uganda. One of them was, of course, the access to the opioids, then the policies that were in place, and specifically whatever you mentioned right now about stepping out of your comfort zone. Clearly, all of these have helped you overcome many of those challenges. Any other, pearls that you would like to share, with, say, a nurse practitioner who wants to set up a nurse-led program in pediatric palliative? What would your advice
in palliative care?
In palliative, let's even palliative care, exactly. So, what would your advice to them be?
It would be to kind of read a bit about it. Go online, see who else is doing things. Ask people, do you know anybody who's doing this that I can talk to in India or outside of India? So find somebody else who wants to champion that as well. And learn from them. So get yourself some kind of support. Don't give up at the first hurdle. Another colleague of mine, Dr. Liz Gwither from South Africa, I remember her quite early on when I was in Uganda saying, we might be low in resources, but we're very resourceful. We find a way around things. So don't give up at the first hurdle. And also, for me, it's not about me. It's about the children and the families, or the adults, the people we're caring for, who need palliative care, and their families, because that's why we're doing it.
Yes.
We are doing it. Okay, if I make a few people grumpy or whatever, it's not about that. It's about what we're trying to do.
The big picture.
It's about the big picture. It's about making sure that the children we care for, and even if you only manage to care for 5 children, you've made a difference in those lives. So not to give up, not to stop at the first hurdle, and to get people around you who can support you, and go for it.
So for all the nurses out there, be resourceful, read up well, don't step out of your comfort zone, don't give up on the first attempt, and
don't think that you can't be the leaders.
And remember the mosquito.
Remember the mosquito, and you can be the leaders.
You could be the leaders.
I remember the first time that I was managing at that time, but doctors. It's like, oh my goodness. There's a nurse managing doctors. So that was quite.
That's a tough task.
That was quite a tough thing, and when I first moved to Uganda and was doing work with the Ministry of Health, everybody assumed I was a medical doctor. I didn't have my PhD then, and I think I've learnt the kind of art or the skill of knowing when to say I'm a nurse, and when not to say anything. So I would never say I was a medical doctor, because I'm not. But there's sometimes, particularly now I have doctor or professor in front of my name, there's sometimes I will just keep quiet and let people think what they think. And there's other times when I will say quite strongly, I'm a nurse. And when I'm advocating for nursing, I think that's really important.
Very crucial. Yeah.
Some leadership tips right there.
Yeah.
And another leadership tip is, I said I was quite shy when I grew up. I'm also an introvert, not an extrovert. And one of the things that I've learnt is that it's important to be yourself and to lead in your own way. I used to work at the African Palliative Care Association with a great person called Dr. Faith Mwangi Powell, and she was very extrovert and she was just very different from me. And I thought, oh, well, I need to be like that.
Yeah.
And then it's like, no, I can't be Faith. I'm not Faith.
Be yourself.
Be yourself. Be yourself, because that's how best you can lead. Don't try and be somebody else.
Yeah, I mean, that makes so much sense, because you will exhaust yourself trying to be someone else, and then you won't end up doing what you set out to do in the first place.
And identity theft is a crime, so
and also recognize as an introvert, I need some space on my own. So if I'm traveling somewhere and people are being very lovely and wanting to take me out to dinner every night, I can't teach all day and be out for dinner all night. I need a bit of time.
So are you cancelling dinner plans for?
No,
Okay.
I'm not.
No, okay.
I'm not. I've just learned actually to say before I go, just to say that I do need a bit of space. So don't feel you need to entertain me all the time.
Yeah.
Because I know myself.
Yeah. This brings us to our next question. What does living well mean to you?
Living well to me means trying to get a balance and doing enough of the things that make your heart sing. So, we all have jobs where not everything makes our heart sing. We have administration and we have forms to fill out, we have whatever. But if you have enough of the things that make your heart sing, the things that you're passionate about, then that is important. What about outside of work? So what is important to you outside of work? Make sure you do that, because that is what will feed you everything else. And something that I've had to learn the hard way is that I will never get my to-do list done. I will never have all my emails answered. So there's no point in me staying up late every night to try and do it, because I never will, and it will just wear me out. So, be aware of what is possible and limitations. But it's getting balance.
Yeah.
Getting enough sleep.
Yeah.
Seeing friends, family, and getting that good balance as to what makes your heart sing. Because if you get that, then your passion will shine through.
Lovely.
Thanks for doing this, and we can see your passion shining through, because you have missed out on a lot of sleep to just be here and do this podcast. You've flown in and you've missed a lot of your sleep, and you're here advocating, you're talking about this.
Yeah.
So we really appreciate you, taking this time out to do this session.
Thank you so much.
Thank you again for asking me.
Thank you.